Hello, my name is Pete Benokin, and I'd like to welcome you to a free education program in regards to the care of the stroke patient. Joni Soames, a Minnesota State Council Emergency Nurses Association longtime member, has put together this wonderful stroke education for you. And so this first slide is just offering you some step-by-step, 1 through 4, how-to, so that you can get your CEU provided for free after you've done the program. Basically, there's 3 parts. You listen to the program, the slide presentation, and then you go to the Minnesota ENA website, back where you started, and you take the quiz. Be sure to put your name and email in there so we can send you your certificate. And then please also go back and complete the course evaluation. Thank you for joining us for this education program.
A quick disclosure slide. It should be noted that TPA given after 3 hours of symptom onset, both IV and intra-arterial are off-label uses according to the FDA. They have not been approved by the FDA for the treatment of stroke, but therefore we are including this slide as disclosure and disclaimer. You should note that the American Heart Association and the American Stroke Association do endorse this use, and therefore that is why we're just being upfront here with the disclosure of an off-label use within our stroke talk in regards to TPA.
So basically this is a talk about stroke. We're going to talk about the identification and initial treatment of patients presenting with stroke symptoms. My name is Joni Soames. I am a staff nurse at St. Joseph Hospital in St. Paul, Minnesota. I have nothing to disclose relating to this offering. There was no funding or financial incentives to have it for you. However, we feel it is good for our patients, our patient care, as well as our nurses throughout the state. Again, remember that this is free education provided to you, and you can receive that information as long as you submit your quiz as well as your evaluation of the course. I think it's important to recognize early on the reason we're offering this education is that we know recognition of stroke symptoms early and recognizing that it depends upon when that patient was last seen in air quotes normal is going to make a huge difference. So early recognition, early treatment is going to be very important with our patients.
There will be some objectives related to this course. You can see them on the screen. We will be sending these objectives into the Emergency Nurses Association to obtain continuing education credit for you. That will be coming as soon as we are able to get your quizzes as well as your course evaluations. Hopefully this will be useful information for each of you. Ultimately, you can read the writing on the screen, and my goal is not to read every one of these slides to you, but it's to help progress you through the program in a reasonable fashion. There are additional goals that we would like to talk about, and the key here is the subtle signs and symptoms of stroke. This course is essentially intended for emergency nurses, but can certainly be used for many other groups out there that look at patients who may be presenting with stroke symptoms. And the subtle signs and symptoms of stroke are one of the things that we're going to focus on, as well as the classic signs and symptoms. We will talk about time frames. And one of the things to remember, I mentioned it earlier, but I will mention it again, is the fact that we need to know the last time the patient was actually seen normal when we start that clock that you see is in our patient's head there on the slide. We know that their time is going to be the critical factor treating stroke, and as fast as we can get those patients to the appropriate care and get them treated, the less problems they will have with their stroke and the higher chance they will have of having a good outcome. So let's start with simply what is a stroke. Basically, stroke is a neurologic deficit. It can be caused by a variety of different things. It can be caused by a clot, which is what typically we think about when we talk about stroke that we can treat and what we will focus on mostly in this program. It could also be caused by a ruptured blood vessel in the brain, and about 15% of the strokes that are out there are caused by ruptured blood vessels. And many times patients will come in with stroke symptoms that turn out are basically stroke mimics, and we will talk about those as well before this program is completed. Classically, if a patient has a bleeding stroke or a stroke that's caused by a burst aneurysm or a vessel that has broken in their head, they will typically complain of the worst headache in their life. They will also have stroke symptoms. So it's going to be very important in the process of assessing your patient that we determine if this is a bleeding stroke or a clot stroke. That's where the CT scan comes into play, and we will talk about the CAT scan or computerized tomography scan later on as we go through the process here. Typically, about 85% of the strokes are clot strokes. They're caused by a clot that's gone to the brain, and those are what we're going to focus on because those are the strokes that ultimately we are able to be treating. Most of the strokes, as I just mentioned, are the result of a clot. They travel to the brain, and most typically they are caused by atrial fibrillation. That's the reason you see so many television ads now about the variety of different medications that will help to keep people from having strokes. These clots can actually originate anywhere in the body, and even damage in the brain itself can cause a clot to form in the brain. But ultimately, the clot is what's causing the brain to not get the blood that it's supposed to and causes the signs and symptoms related to the stroke. So what happens when a clot goes to the brain, which is what we're focusing on, is basically an area of the brain, and you can see it right there, that where there's a clot, and the rest of that brain area is not getting any blood. In addition, it's not getting oxygen, and it's not getting any glucose, and that's the reason those cells are starting to die, because ultimately those cells need to have both of those things, as well as get rid of the byproducts of metabolism. It needs to be drained from the brain, and if there's a blockage, that's not going to happen. Your brain cells are starting to die, and the clock starts to tick. I will give you the first number that you need to think about. We know that we can treat strokes if we see the patient within 4.5 hours of that clot occluding that blood vessel, and we can do that intravenously. All of the hospitals in Minnesota actually have that ability to do, so we just need to set up the process or describe the process, how we can manage to start treating those strokes. But we do have a very limited time frame of those before those cells start to die permanently, and that's why we need to have a system in place as well as a process to make that system work well and get that patient treated quickly. This slide here actually gives us kind of an idea of how quickly these cells are dying. Part of the reason that we have to move fast, because we do know that the longer the stroke goes on, the more brain cells we're losing, the more neurons and synapses we're losing, the more years in life we're actually losing with our patient. This is kind of a fun chart. I will tell you nothing on the quiz related to this chart, but ultimately know that we need to move quickly. The second reason we need to move quickly, and we will allude to this later on in this lecture, is the fact that we know for some reason if we start to reestablish blood flow in the brain after that 4.5 hour time frame with IV thrombolytics, for some reason the patients seem to have a much higher risk of rupturing that blood vessel and then developing a bleed stroke. In the long run, we know that the bleed stroke will have much more bad outcome than the person who simply has the clot stroke. For why that is, I don't have a good reason for that, but we have certainly seen it anecdotally, and I'm sure there's a researcher out there that could give me a great story about that. But ultimately, we know that we need to act quickly. So basically, what we need to be able to do is recognize when a patient is having stroke symptoms, and that's what we're going to talk about, is that early recognition. We know that patients will come in with some symptoms, but what exactly are they? Basically, I think it's important to recognize symptoms of a stroke will really depend upon the vessel that's being affected in the area of the brain that is dying. Additionally, keep in mind that whenever you have injury, there is some ischemia that occurs around that injury itself and some inflammation that will take place. Often we see that this person develops this big stroke symptom, and then they tend to get better over a period of time. And that's because that inflammatory process seems to disappear. And if we can treat these people quickly, you'll find that they have less symptoms because we've decreased the amount of inflammation. That inflamed area is actually called the penumbra. There's a special fancy name for it. On the slide, you can see that darkened area of where the letter A is located. And we know that if we can reestablish blood flow, that penumbra will actually recover and not die. And so the patient will have less symptoms. Sometimes when we treat the patient early enough, all of the symptoms go away. But the key here is that if we can reverse or save the penumbra, you'll find that your patient ultimately does better in the long run. So let's talk about the symptoms that the patient will present with. And we'll start with basically the classic picture of a stroke patient. Here's a gentleman who has the classic facial droop, arm and leg weakness, speech difficulties, and then T, time to call 911. And currently this is the mnemonic that we're teaching to everyone. You'll see it on television. You'll hear it on radio. You see it in magazines. They talk about a fast exam, and it reminds people that the classic symptoms need to be seen right away. The challenge here is that we realize not everyone has classic symptoms. And as I mentioned, I'm a staff nurse at St. Joe's Hospital in the emergency room, and ultimately there were days that we were seeing or calling stroke codes 6 to 8 times in one shift, because what we were quickly learning is the symptoms could be very subtle, they can be very generalized, and their symptoms will not always be the classic ones. What we learned was many people have small strokes, not always big strokes, and if we can recognize these small strokes, we can often change the quality of that patient's life. So the key we're starting to look at when we were in triage was symptoms that would suddenly appear. Any sudden neurologic deficit would be one of the things that we would say, this could possibly be a stroke. And as you can see, we have a picture of the motor as well as the sensory function strips in the slide here. These are some of the things we were looking for. We are actually going to go through a lot of these as the slides go on, simply to show to you that, in fact, you need to be looking for all kinds of symptoms, not just the classic ones. Those classic ones are for our patients to recognize. They need to get in. We want to be a little bit more aggressive and determine if someone is having a subtle stroke instead of one of the big ones. In the long run, again, remember, better patient outcome. So some things to think about when someone would come into the triage area where I may be is looking at signs and symptoms. And remember, not all patients walk into triage with a stroke. Many of them come in with the classic symptoms via ambulance. We'll talk about that as well. But just as many subtle stroke symptom patients appear at your desk. They may complain of symptoms on the entire side. They may, or the entire side, arm and leg. They may have both or just parts of their side. They may come in with a numb arm or a numb leg or a numb face. They may come in probably via ambulance with both sides having sudden onset of neurologic symptoms. So the key here is sudden onset neurologic, and we'll talk about each of those a little bit more. The deficits may be motor. They're having trouble moving things. They don't have to be both motor and sensory. They can just simply be motor. They may be sensory only. They may have trouble just feeling an arm or a leg or their face. These may be mimics, but they may well be a true stroke that you're looking at with this patient. They may be having trouble thinking or processing, and many times they have no other symptoms other than thinking or processing thing. They may have global symptoms that something is just not right, but it was a sudden onset of things are just not right. And if that's the case, you need to, in the back of your brain, always still be thinking, could this patient be having a stroke? Sometimes the patient may actually have a visual or a spatial problem. They may have neglect and ignoring of one side. This may present as they're having trouble seeing or recognizing that there's someone on their left side, and yet they know everybody's going, the things that are going on their right side. They may be having trouble with their vision and not even, it's blurry to them, and what they don't realize until they close one eye is that they're only seeing out of one eye. So if you've got somebody who's having, like, walking crooked or walking funny or driving funny, you might need to think, could this in fact be a stroke that this person is having? When they lay on the bed, you may find that if you're not on the side that they see you, they may not even recognize that you're there. If you move on to the side where they can see you, it's like they'll interact with you fine. But if you're on that neglect side, they may not know you're there. They may not know that something bad is happening to their arm or their leg, even though they could theoretically move it. They can't. They don't know that it's there to move it if something bad is happening, like it's caught in the edge of the bed or somebody's, doing something that's painful to it. One of the other things to consider as you're looking at these patients that present, it is not always necessarily a physical thing that they may come in. Depending upon what vessel is occluded, it could simply be a skill set. We had one person come in who simply couldn't text as quickly as possible. I've had other patients come in that couldn't do math or couldn't read or couldn't recognize words or colors were off. And these are all sometimes these skills that are like, if you didn't even use it every single day, you may not even know that it's missing. And the patient might come in and say, I suddenly can't do the taxes anymore because I can't do math. Well, for me, that'd be no big whoop because I don't do my checkbook on a fairly regular basis. But if I was a tax accountant, that would be a huge deal. Or if you had somebody who was a great movie producer who suddenly had a stroke in the area that was his creative area, you'd find that this would probably be life-threatening to him, or certainly it would affect his life significantly. So just as some examples, here are some of the strange strokes that we've caught over the years. Probably the one that we were the most happy with was the young gal. She was only a high school senior, couldn't text as fast. It's like, I can't text at all, but she couldn't text as fast as normal. And when we actually scanned her, she didn't have a clot stroke going on, but had some aneurysms with some bleeding stroke going on. So it was the sudden onset of inability to text. We have had the person who couldn't do the math as well, or the person who was an educator who suddenly couldn't recognize words on paper and realize that. A story we heard about was the patient who came in complaining of a sudden onset of numbness in their leg, but had a history of chronic back pain, so everybody kind of made the assumption it was related to the back pain. It turned out later on, in fact, that patient had had a stroke that simply had affected that leg, and that was the only symptom they were having. Another story I heard about was the person who came in that has a stumbling gait or ataxia, which we'll talk more about later on. The patient also was under the influence. But it turned out that as they continued to monitor that patient, it was a stroke that was causing the stumbling, not the fact that the patient was also under the influence. The weirdest was the lady that came in, and the reason she came was because she said the colors were off in the fruit at the grocery store, and it turned out that, in fact, her stroke was in a part of the brain that affected the color of everything. And ultimately, that was how we caught her stroke, was because of buying fruit. I know, kind of weird, but when it's a sudden onset of something neurologic related, we need to think about, could this possibly be a stroke? So the key here is that stroke symptoms will vary based on the location of the injury to the brain and what that brain function is. Be suspicious of any neurologic deficit, which will help to identify even some of the subtle strokes that you're seeing. So let's look at some of the different symptoms and some of the vessels. So basically, oh my gosh, what are we going to do? We're going to talk about brain anatomy and physiology. Ooh, that sounds scary. I guess I should put a disclaimer in there. We're not going to turn you into a neurologist with this course. We're also not going to have you in your practice be able to identify what blood vessels are being affected by the symptoms. I can tell you, after a while, you work with some of the neurologists who've done this often enough, and they get to the point, based on symptoms, they can tell you exactly which vessel it is, and probably even where in the vessel the occlusion is. Because as you start to map out the brain, you get a pretty good idea of what symptoms are caused by what occlusion. We're not going to get you to that good. What we're going to say is you should be able to identify neurologic deficits and know that this is probably a stroke. We're also going to, as we go through this, we're going to share some common stroke mimics, and this is another disclaimer I want to put in there right away. It's always important to think stroke, not stroke mimic, when you're looking at your patient. And don't assume that when they're coming in with neurologic deficits that it's just going to be hypoglycemia, or, it's just going to be Bell's palsy, or, it's just going to be. But instead think, this is a stroke, but make sure that you do the rule-outs for the stroke as well as rule-out for the mimics. And don't feel stupid if you say, oh, my God, I think I've got a stroke thing going on, and in reality it ends up being a stroke mimic. It's better to think for your patient that this is a stroke that's happening and rule it out. Yeah, sometimes you'll take a little flack from the physician because you overcalled it, but the time that you end up calling one right that they would have missed makes you feel so much better. So, as I mentioned, we're going to start by reviewing brain anatomy and classic symptoms that you might see if there is a clot in one of the vessels in the brain. You may want to, as you go through, I'll mention to you which areas you may want to remember, which symptoms you might want to remember for the quiz, because I know you're all nervous about the quiz, but ultimately we'll make sure that you learn material and you remember for the quiz. And then if you want to forget it for the rest of your life, which vessel is which, that's okay. But it's kind of fun to figure out what's going on with your patient if you can remember those. So, basically, when you are looking at cerebral arteries in the brain, the most commonly described vessels that we talk about during stroke are the anterior cerebral artery, the posterior cerebral artery, the middle cerebral artery, and the basilar or basilar, depending upon who you hear talk about it, cerebral artery. Basically, also kind of keep in mind that typically the side of the vessel, or the side of the brain that the vessel is being affected, is actually going to affect the opposite side of the body. There will be some cases where that doesn't happen. We'll talk about those. But pretty typically, if you have someone who has right-sided deficits, you know that essentially the injury is on the left side of the body and vice versa. So here is one picture. We're going to have a bunch of pictures, and thank goodness for Dr. Netter. He does some really awesome pictures of the anatomy of the body. Basically, in this picture, you can see all four of them kind of like, to me, this is one of these slides that there's just way too much on it for me. But you can see in blue the middle cerebral artery, at least one version of it, as it comes off of that circle of Willis, which is in the very center there. You can see the basilar artery, which is that central one, actually comes up the brainstem across the medulla. That's in the darker blue. The posterior cerebral artery is not a really great picture yet. We'll get a better one of that in a little bit in the green. And then the anterior cerebral artery is located or pointed out with the yellow arrow related to that. We're going to look at each one of these separately. We're also going to look at each one of them. That will give you an idea of what they do to that patient. So initially we were just going to let you read everything here, but now since I'm talking to you, we could probably almost go through this slide without you reading it. We're going to talk about the anterior cerebral artery. Basically, it starts in the base of the brain at the very bottom. It travels to the front of the brain, and then it does almost a 90-degree U-turn and goes to the back of the brain. So depending upon which part of this anterior cerebral artery is occluded, you're going to see some different symptoms. Let me go to the next picture and it'll make more sense. So as you can see, the anterior cerebral artery starts out right off at the circle of Willis there. It's outlined in blue. There's two of them. There's the right-sided, there's the left-sided. It comes up, does the front of the brain with a lot of little branches that you're not seeing there, going to the frontal lobe, and that will explain why some of the symptoms the patients have are so much more frontal, then goes towards the back. And basically, if you recognize here how in the center, basically the midbrain, or where the brain divides, is where you see a lot of the branches come off of this anterior cerebral artery. So it's going to give the patient symptoms related to that particular part of the brain. So you can see here is the anterior cerebral artery coming off the circle of Willis, and the blue arrow points to it. The little yellow ball kind of paths it for you, but you can see all of the various branches. And it's basically, if you divided the brain in half, that's where it travels, all the way through the front, all the way through the back, and you can see a lot of different branches reaching out, perfusing a whole lot of the brain related to that. So that's your anterior cerebral artery. And typically, if someone has an occlusion to that anterior cerebral artery, you see them come in and they will complain of things like they're clumsy. It's the opposite-sided. Typically, the foot or the thigh is giving them some problems, and it may be more weakness rather than absolute inability to move. It's just not working as well as it should be. It's a little bit of a kind of a numbness. And they're not as good with their shoulder when they're trying to reach. And later on, as we look at the motor and the sensory part of the brain, you'll see that this area kind of works with it. They interlace with each other, and that's why you sometimes see symptoms that are similar for two vessels, simply because they overlap with each other. But often people with anterior cerebral artery occlusions are more of a weakness and a clumsiness than an absolute paralysis and lack of ability to feel. They also have a tendency to have thought process problems. These are the people that are just like they're kind of almost, they're not there completely. They're slow to initiate responses when you talk to them. They have more trouble with their memory. They tend to be a little bit more apathetic, and often they can't even talk, and it's not because the talk mechanism is gone, but it's the ability of them to come up with words to talk about are the folks that are having issues with that. They may have impulsivity, and one of the things that we've noticed is often our patients who have more problems with saying the politically correct things or acting correctly, if they're having issues with this, this may be the result of an anterior cerebral artery occlusion. And many times we see these folks in rehab longer simply because they have trouble filtering out the rest of the world as well as their behaviors, and they sometimes get into some trouble. We see these people often, for some reason, also have more problems with incontinence, and they have trouble with concentration. So some very often vague symptoms when these people present, and it's when they have this sudden onset that you kind of wonder, what's going on with this person? The next area we're going to talk about is the posterior cerebral artery, and these are the vessels that go to the back of the brain. This is the area that often you don't pick up very easily because there's a real good communicating system in there and collateral circulation. So often we don't recognize these people coming in with the symptoms that they have. There we go. You can see the little arrow kind of pointing to the posterior cerebral artery as well as the little ball giving you an idea of where that blood travels to. You can also see many of the communicating arteries that come off of this posterior cerebral artery. You get a good knock to the back of your head ever, and that's why you see stars. Well, remember, that's where some of your vision is back in this particular area. So I'll bet you can guess when we come to the signs and symptoms in a few minutes what this person's going to complain of. So some of the classic symptoms of a person who has a posterior cerebral artery occlusion, yes, they have some opposite-sided sensory loss. They may have some opposite-sided paralysis. But oddly enough, they have a lot more eye problems. They'll have eyes that are moving different directions at different times, that disconjugate type of eye movement. You may see nystagmus in this person to the point that, you have them, when you have them go back and forth with their eyes, they bounce back and forth and back and forth and back and forth. You may see some other cranial nerve involvement simply because this is so close to where the cranial nerves are coming out of the brainstem here. I've also got another slide that'll talk about some other symptoms that we've noticed over the years. Again, it's tough often to see these guys, but the patients with these symptoms, but every so often you'll run into someone who complains of a sudden onset of visual field loss, or they have trouble naming an object. It's very odd. If you say, what is that thing, and you point to a cup, they can't tell you that it's a cup. But they could, if you say, draw me a picture of a cup, they can draw a beautiful picture of a cup. Oh, that's assuming they could draw before. Or they can point to the cup themselves, but they can't put a name to what it is. That's the reason when we do the NIH stroke scale later on, you'll see that we ask them to describe what's going on in a picture because we're actually checking for visual agnosia. They may have reading disorders because they can't put the words together or the letters together. This is the person who has color changes in their vision. A very interesting one is blind to sight. It's a person who will be walking along and all of a sudden walk around something, and you say, why did you just change the way you're walking? And they go, I have no idea. They walked around a chair, but they did not see the chair there. At least they can't tell you that they see the chair there. So it's some often very interesting symptoms when that posterior artery occlusion occurs, but it's usually related to where they are and what they're doing. They may actually have coma. They will often have memory impairment. But ultimately, this is one of those ones that may be a little tougher to pick up. So if a patient comes in with odd symptoms, don't be afraid to say, I wonder if this is a stroke, because in reality, that's exactly what it could be. Probably the stroke that I have seen the most common over the last several years as I've been taking care of patients related to strokes has been a middle cerebral artery, or you hear the doc call it a MCA stroke. And basically, this is, to me, like the artery that does like the whole and entire brain. Now, the key here is that as big as this artery is, there are a lot of distal branches. So the patient may not have a major occlusion, but may have a minor occlusion of one of the middle cerebral artery branches, and the patient may have symptoms. Also remember, a lot of our vessels overlap in the brain, and so you may have a patient who is having some symptoms but not as many symptoms as you anticipate simply because of the collateral circulation. So here shows one picture pointed out in green. This is the left middle cerebral artery that you can see that comes out from that circle of Willis and basically does a lot of the outer side of the brain. There's a lot of branches on the outside. You'll find that in a few more pictures there's also a lot of branches on the inside. This vessel is huge, it's big, and this is the one that when a patient comes in with major symptoms, this is classically the vessel that's occluded. Here shows another version of the middle cerebral artery on the outside of the brain again. You can see how it spreads all over. It's a little less messy than the previous slide, so you get a little bit better picture of it. And here is the blood vessel, or where the blood vessel functions. You can see the motor strip and the sensory strip, and thus you can see the reason that a patient who has a middle cerebral artery occlusion is going to have many problems. If you remember this slide just previous, you saw how it covered so much of this particular part of the brain. Well, you can see that it covers motor, sensory, hearing, language, and even some with the emotion. So you've got a patient, if they have an occlusion that covers all of these areas, they're going to have a significant stroke. If you have a branch that's occluded, you're going to find that that patient's going to have less symptoms. And that's one of the reasons that often we have to do so many tests. And we'll talk about those in a few moments. Here is a picture of the parts of the brain that are affected when the major part of the branch of the middle cerebral artery is occluded, or the beginning or the proximal area is occluded. As that occlusion gets more distal, you're going to see less and less symptoms. But the classic symptoms are the opposite-sided weakness, tends to be more in the arms and the face than in the arms and the leg, or arms and legs, but you will see probably the entire body affected. You'll also see entire one-sided, and both of these are one-sided, sensory loss. when we check the patient, what we want to do is check for visual field loss, because you will find that they will typically, with a classic stroke and a huge occlusion, will actually have some loss of vision. And interestingly enough, that can be right or left-sided. We'll talk a little bit more about that later on. If the left middle cerebral artery is occluded, the patient is going to have a hard time speaking to you. Remember, aphasia with the S is speaking as opposed to G for gagging. So they're going to have trouble speaking if it's the left middle cerebral artery. If it's the right middle cerebral artery that's occluded, you're going to find that often they have neglect, and that's a person who you could do horrible things to their left side and they don't realize that you're even there, because they totally do not know that that left side is going on. This is the patient who often, if you don't go on the right side of the bed, they don't even know that you're in the room with them. So we're going to talk a little bit more about this as we go on here. So remember, that middle cerebral artery is most commonly seen and recognized. We're going to talk a little bit more about this, and we're focusing here on the motor function and the sensory function, because ultimately these are the things that we're checking for when many of our patients come in. The homunculus, which I've always thought is kind of a cool thing, he's that little guy that's drawn in the brain, and what I will note to you is actually, although I couldn't get a picture of one with the leg and the foot down in the central sulcus, or where those little X's are, typically that's actually where those parts of the body are innervated or perfused. So typically, actually, you sometimes will see more symptoms there, because remember, that's where the anterior cerebral artery flowed and perfused that section of the brain. The middle cerebral artery, which you can actually see there in red, does more of the face and the lips and the eyes and the hands and some of the trunk there. So that's why you see sometimes some little bit different distribution. You can certainly spend a little bit more time looking at this picture here, but ultimately, when you're looking at your patient, if you're just looking for symptoms and recognizing that a weakness or a numbness in their leg, or a weakness or a numbness in their arm are potential signs of a stroke because they are of a sudden onset in nature, then ultimately it doesn't matter if you know if it's an anterior or a middle cerebral artery. The key is you recognize that this is a patient who is having stroke symptoms, and we need to call a stroke code on that person. Also keep in mind that as you look at this, you can see teeny little fingerling vessels coming off that middle cerebral artery there. Keep in mind that a small area may simply be occluded rather than a large area being occluded. So you may see only an arm, or only a hand, or only the mouth, or only the shoulder, or only the tongue. Depending upon where that patient is occluded, you may have very subtle and isolated symptoms, or you may have major symptoms. So don't not call a stroke code just because it's not the entire side that's being affected. It may be something that's very simple, and that's because it's just a small vessel being occluded. So ultimately here, we've noted patients with an anterior cerebral artery seems to have more leg weakness as opposed to the person with a middle cerebral artery. Remember, as you look at this picture here, remember where the leg was on the Mr. Homunculus? More in the center where that anterior cerebral artery is. Arm stuff would be more where the middle cerebral artery is. And that's just the reason why we see these different symptoms. As I mentioned earlier, don't get hung up on which one's which. More keep in mind that we have that sudden onset, and we should be concerned it's a stroke. Also keep in mind, we mentioned this a little bit earlier, your symptoms will typically cross. So the injury that the patient has in the brain on the left side is going to cause more symptoms on the right side, and the injury that's in the right side of the brain is going to affect more the left side on the patient. Does it matter? Probably not, unless you're into a lot of reading of CTs. But ultimately, sometimes it's just kind of nice to know what's going on with your patient. One of the things we've also realized over the years is sometimes some stroke symptoms are so subtle you may not even pick up. And for instance, the patient who comes in with confusion or delirium, which you actually heard about a little bit earlier, could be someone who is not so much confused but having aphasia. And the aphasia typically goes along with the middle cerebral artery. Now, remember, if they're acting like they're out of it, that may be more anterior cerebral artery, but speaking things would be more middle cerebral artery. The risk with any of these strokes, in reality, is even though this person comes in with only inability to speak, it could be that the clot gets bigger, and as that clot gets bigger, you'll find, especially with the middle cerebral artery, that they have more symptoms and the stroke will progress. So if you have somebody who's coming in and having speaking issues for a day or two, but now suddenly is also having trouble moving on one side, you need to be considering when did those symptoms start. And the last known normal would have been the symptoms speaking issues were, as opposed to when now are they having trouble moving. But that would be one of those things where the neurologist would have to decide, when did that stroke really start? Was it more like transient ischemic attack symptoms where they were just having speaking trouble and they were still perfusing the rest of the brain enough that it's worth the risk of giving the TPA? Or is this neurologist going to say, you know what, when that speaking trouble started 3 days ago, that's when the stroke started, and I'm very fearful if I give the TPA that they may have the bleeding as a result of it. And you may run into the neurologist who say, I'm not going to treat this stroke because of the risk. So know that ultimately the neurologist has to make the decision based on symptoms and that last known well time of all of the symptoms the patient is presenting with. And if you've got a stroke that's evolving, that's one of the ones that are tough, because they're going to have to make that call knowing that the ultimate risk, again, is that the patient may convert from a clot stroke to a hemorrhagic stroke. Blurry vision, I mentioned that a little bit earlier. It might be one of those things to kind of keep in mind that the patient may come in with a variety of different visual field loss. So typically when you have a patient come in who's having stroke symptoms, what you'd basically like to do is tell them, stare at my nose, meaning your own, and then just check all 4 quadrants of their vision, wiggling your fingers. And basically you just make a box of wiggle fingers on the bottom right quadrant, upper right quadrant, upper left quadrant, lower left quadrant of the first eye, and then switch over and wiggle fingers in all 4 boxes in front of the eye on the other side. And if the patient is having any trouble looking or seeing your fingers wiggling, you need to recognize that they are having a field loss. And it could be that they're having just one eye is blind. They may have trouble with the outside parts of both eyes being unable to see, a bottom quarter, an upper quarter. And when they report to you, all they have is suddenly I have blurred vision. They don't realize that, in fact, what they're having is a visual field loss. So one of the things that we always recommend is checking to see what their vision is like. If you do a full NIH stroke scale, or if you're doing what many places are doing, which is an abbreviated one, the down and dirty quick one. So you still want to check and see what their vision is like and not just count on them to say, my vision is fine. You really want to check both eyes independently. So this is a picture of what they might come in with, complaining of isolated visual field loss. And we have had actually people come in with simply isolated field cuts. They come in because they were in a car accident. They come in because they think they have one of those migraines that's blinded them. They come in because they think they need new glasses. And as you're doing the assessment, you realize that this was a sudden onset. Or they're only seeing half of the Reader's Digest page. We actually had someone come in who could only see half of a page, and that was the reason they were coming in, because they couldn't read their book the way they liked to. So basically, the key here is that depending upon the size and the clot and the location of the clot, you're going to have different symptoms. Sometimes the symptoms are so subtle that you don't even see symptoms in the patient. And there will be times where you will have a report come back from the radiologist that says that they've had a stroke, they've had a lacunar stroke, and ultimately the part of the brain that was affected and the part of the brain that died was so small that it didn't affect the patient's life, or at least to the point that they recognized it. I sometimes wonder if the reason I can't remember certain people's phone numbers is all because I probably had a little stroke somewhere along the line in the area where I remember phone numbers. So when I never call you back, it's because I can't remember your number. No, just a joke, sorry. The last set of slides we're going to look at here related to stroke are the posterior cerebral artery vessels. This is the one who is very interesting. This is the one where the patient may actually have bilateral symptoms rather than one-sided symptoms. This is the person who scares me the most because this is the person who is affecting the brain stem. This is the person who may come in with very subtle symptoms, but as that stroke or the penumbra gets bigger, you actually start to watch your patient deteriorate in front of you because ultimately it affects so many of the basic parts of the brain. We're going to kind of talk about those just next. So here is the posterior cerebral artery. You can see the green arrow pointing to it. You see how it goes up to the circle of Willis. Everybody else kind of had a little bit of other collateral circulation affecting other parts of the brain, not perfectly perfusing it, but typically kind of picking up and taking over for some parts of the vessels that are occluded. But man, I'll tell you, if you're going to completely occlude your basilar cerebral artery, there is no backup for this guy here. Also keep in mind, and we'll look at another picture in just a moment, it perfuses some pretty significant parts of your brain and your brainstem that control your heartbeat, your respiratory rates, your blood pressure, your level of consciousness. If you go all the way back to anatomy and physiology, remember this is an important part of your brain and how it worked. Here just shows another picture of it laterally, and you can see right up the brainstem. And remember, these folks can be really sick because they have blood pressures that are out of whack, respiratory rates that are out of whack, pulse rates that are out of whack. They have altered mental status or changes in level of consciousness. I've seen them come in with very minimal symptoms, like the back of my throat feels full, and I have a hard time swallowing to the point that they're totally unconscious, and we're ventilating them. When they come in, if they're not totally out of it, in a coma, which I have seen, they might complain of some dizziness problems. When they're awake and alert, they may complain, or you'll notice the basic body function, pulse, heart rate, respiratory rate. This is the person because instead of crossing over, this covers both sides of the brainstem. They may have bilateral sensory loss, bilateral paralysis, lack of muscle tone because of the paralysis, or they may simply have cranial facial nerve involvement, and we're going to look at those in the next slide. Oh, man, you remember these from school? You know, I learned on old Olympus Towering Tops, Finn and German viewed some hops to tell us or remind us about the olfactory, the optic, the oculomotor, the trigeminal, all of the other different nerves that we needed to learn and memorize, which we, of course, never learned or used later on. But ultimately, if you have someone who is not perfusing the brainstem, which is what the posterior artery does, the basilar artery does, what you'll find is the patient may have symptoms associated with these nerves. So they may come in and say suddenly nothing tastes right, or they suddenly can't smell things, or they're having trouble with hearing or swallowing, or they may have some facial things that are going on, or some trouble with their eyes. So the signs and symptoms that go along with this particular nerve make, pretty much sense when they come in with facial things or airway things. When these patients come in with these occlusions, unfortunately they're not too often. You've got a patient who can have some very vague symptoms, and they're a tough one to pick up. Again, it's when did they first notice it, and when was the last time they thought it was normal, or they knew it was normal is better the word to use, that may make you start thinking, could this be a stroke that this person is having? It just shows one more picture, and the brown thing that's growing on your slide there reminds you that sometimes you may have a very small clot that will ultimately take you patient from being stable with vague symptoms to unstable if either the clot or the ischemia spreads into the pons and the medulla. So if you've got a patient who has a large clot there, you're going to start to see changes in symptoms. They're not going to be able to handle secretions, their blood pressure, their heart rate may start to change, their respiratory rate may change. They may develop progressive weakness and paralysis. You may see that they ultimately develop altered mental status as their symptoms continue. So it's one of these ones that fortunately is pretty rare, but when a patient comes in with these symptoms, don't be afraid to say, could this possibly be a stroke, and when was the last time someone saw this person, their normal behavior. One of the strokes or the stroke symptoms that presents often with this particular occlusion is the dizziness. The person will come in with horrible, horrible dizziness, and it's often passed off as, oh, they've got labyrinthitis, or oh, they've got Meniere's, or oops, give them some meclizine and it'll go away. But isolated vertigo could be brainstem or cerebellar problems related to that posterior cerebral, I keep saying it posterior, basilar cerebral artery occlusion. And this is a person who has uncontrollable nystagmus, uncontrollable vomiting. They can't stand up. And if that basilar artery is occluded, that may be exactly what's going on with this person, and it should be considered a stroke until proven otherwise. Oddly enough, if you were to do an NIH stroke scale on this person, they do not have any symptoms that account for that. And it's been an interesting controversy with some of the neurologists whether or not a nurse should call a stroke code on someone who has isolated vertigo, because they often do not have the criteria. More and more we're saying if you've got a patient who comes in with horrible, horrible vertigo, think stroke and let the neurologist make the decision. When did that dizziness start, and is it something that needs to be treated with that patient? So I think we've gone through a lot of symptoms. We've gone through a lot of different anatomy with the patient, and it's easy to see that a stroke may appear with a variety of different deficits. Sometimes they're very obvious, sometimes they're very subtle, and that is the reason we have developed a systematic approach to assessing the neurologic status. The NIHSS, or National Institute of Health Stroke Scale, which everybody does, everybody is required to do at least once when a stroke patient arrives, and then they continue to repeat the stroke scale over the next several days, will give us an idea of A, what type of symptoms they're having, B, where they're heading or progressing, as well as how have they progressed over the next several weeks to see if the patient's getting better or worse. We also know that the worse the symptoms are, the more poor outcome that patient is going to have. So it's one of those things that we'd like to be able to at least review with you. Maybe your physicians are going to do it where you're at. If you're lucky enough to have residents, maybe your residents are going to do it. Many critical care stroke units, the nurses do it. Many ERs, the ER nurse will do the NIH stroke scale. Some of them do the abbreviated stroke scale. But ultimately, when that patient first arrives, they need to have an NIHSS stroke scale, and we're going to go through it. We're not going to make you experts at it, but ultimately we're going to give you a good idea of what it looks like. We did not incorporate an NIH stroke scale piece of paper into this program yet. We may do it in the future, but if you simply Google NIH stroke scale, there's a lot of them you can print off, and it's almost easier if you print it off yourself, simply because it's that way it's handy for you to have. Again, we don't expect to make you an expert on the NIH stroke scale. Know that you can become certified in it, and there's several places that require that. If there's additional information or education you'd like to do, that would be one of the ones that I would recommend. The American Heart Association is one of the groups that has NIH stroke scale training and validation. But for today, if you wanted to Google NIH stroke scale, you could find several versions of them for printing off for reference while you do this. But in reality, we will not make you do one of those for today. So it's now just a little bit of teaching to see what is included when someone does this. So basically, there's a variety of different things. There's 11 parameters that we're going to assess on our patient. This first page here, and then the second page here will give you an overview of them. One of the things to keep in mind is a 0 is one of the first is a better score. So it's not often you want to be a 0, but today you want to be a 0. If someone's doing a stroke scale on you, the higher the score, the worse outcome that patient is going to have. Sometimes you have to put in a funny little picture, and basically we're going to walk through the steps of the NIH stroke scale. Remember, we're not going to validate you. We're just going to give you an idea of what the doc is assessing. If you're in a facility that does an abbreviated NIH stroke scale and someone else is doing a full NIH stroke scale, what I would recommend is tag along behind the person doing the full one, because in reality the abbreviated NIH stroke scale has the same components. We're just not doing absolutely everything when we do it, and we'll talk about that a little bit later on. But I know in my ER, we do the down and dirty one while our residents do the full NIH stroke scale. However, we give them the NIH stroke scale to follow as they're doing it, the procedure, and we kind of watch them. So we make sure they get them all done, and then we correlate our numbers so we agree as we're going through. So the first thing that you're going to do is as you walk in the room with your patient who's having their stroke, and keep in mind this is probably the person who's landed on the bed, or maybe you're doing it, they come in with some symptoms. They say, my arm is numb, and you're thinking, holy cow, when did it happen? When was the last time your arm was normal? And they say, 2 hours ago, and say, okay, well, let's get you back to your room, because I'm thinking the last time normal with a sudden onset of a neurodeficit, I'm going to get you back. I'm going to call a stroke code. And you're probably making the assessment. And the first thing that you're thinking about is level of consciousness. And is the patient alert, keenly responsive, or are they not alert at all? Can you only arouse them by doing stimulation to them or something like that? Do they respond to whatever's happening? Do you have to do something painful? Are they totally unresponsive? The second thing you're thinking about related to level of consciousness is, can they answer 2 questions? The questions are, tell me your name and tell me the date. Can they answer both of them correctly, one of them correctly, or neither of them? And you can see the points that they get. The points do matter as you're going through this. The third thing you're going to do is basically ask them to do 2 things, and it only has to be, are they following the commands? It's not checking to see if they have the motor or the sensory component. It's, can they follow the commands with the side of their body that's working? So can they open and close their eyes? Can they open and close their hand? If they can do both, they get 0 points, which is a good thing. If they can do neither, they get 2 points. And that means they're not processing your command as opposed to not being able to move that side. So you actually have them do this with their, in quotes, good side rather than their bad side. The second step that you're looking at is the patient's ability to follow your finger back and forth. What you're looking for is that nystagmus. Do they get some palsy? Can they actually move their eyes completely back and forth? And they should be able to track back and forth. The third thing you're looking at, remember we talked about visual field cuts. You're actually doing this now. And you can see the eye here is divided into 4 quadrants. You're going to have them look at your nose, and you're going to wiggle your finger, basically bottom, bottom, top, top, or whichever order you'd like to, and determine if they have field loss. And believe it or not, you might think, oh, they'd never be able to. As long as they're looking at your nose, you actually can pick up if they're having field loss or visual field cuts. Sometimes they're so out of it they can't tell you, And I have seen neurologists actually take and like poke their finger at the person's eye and see if they blink. And if they blink, then you know that they're seeing that finger, and it shows you that there is no visual field loss, or there's a huge amount of trust in them poking their finger at you, or you poking their finger at them. I had a neurologist one day. She says, "Let me show you this," and she says, "You never blinked." And I said, "I knew you'd never poke me in the eye." And she says, "But man, those are good reflexes." The fourth thing we are going to do at this point there is basically ask the patient to smile, and what you're looking for is facial palsy. You can actually smile to them so that they can follow you if they're not following commands, but if they do what you do, if they smile, what you're looking for is a symmetrical facial movement. The nasolabial fold is basically that little crease between your nose and on the side of your mouth there, if that flattens or not. One of the tricks that I've heard from a neurologist is basically count the number of teeth that you can see when the patient smiles, comparing from the middle to the side to the middle to the side. And if you're seeing more teeth on one side than the other side, then you have to assume that they have some facial palsy. Are they able to close their eyes tight? And if they're not able to do that as well, that would tell you that they have some facial palsy. The next area that we're going to assess is the motor arm, and we're going to do motor right and motor left. Essentially what you'd like to do is have your patient hold their arm straight out and count to 10 in a manner not really like 1, 2, 3, 4, 5, but it's like 1, 2, 3, 4, etc. Essentially what you'd like to do is see that patient hold their arm straight out for a full 10 seconds. If you start to notice that it's drifting, then you give them 1 point. If you find that they can't hold their arm completely up, but they hold it up a little bit, give them 2 points. If there's no movement at all or no shoulder shrug, they're going to get a 4 point. If they try but they just can't keep that arm up, then you're going to give them 3 points. If you have a patient who has an amputation or a joint fusion or something, you put unable rather than putting like 4. And a good case there that I've seen frequently is the patient who's recently had shoulder surgery. And it's hardly fair to expect them to hold their arm straight out for 10 seconds if they've just recently had surgery on that arm. So that's one of those things to consider. The next thing that we're going to look at is the motor of the leg. And essentially now you have them hold their leg up for 5 seconds. If you start to see a bounce before the end of 5 seconds, you give them 1 point. But if the leg actually hits the bed, you're going to give them 3 points. If they have no movement at all, they're going to give 4 points. And again, if they have something wrong with their hip, this would be the person who you're probably going to put unable to rather than giving them 4 points. But ultimately you want to be able to see if they can hold their leg up, first the right one and then the left one. I have noticed over the years often we end up doing the arms together, but we do the legs separately. Probably a good idea. Ataxia is the next one, which is kind of one of those tough ones. And typically you've always only ever seen ataxia tested as the person who you ask them to put their leg up and down their shin or have their finger to their nose, and we'll talk about those in a second. The other way ataxia may present is the person who has trouble walking a straight line, and it's a sudden onset of this. So the first patient we presented here is the patient who cannot walk a straight line, and it has nothing to do with them being inebriated. However, that may be the cause for what's going on. The other two are the more traditional methods, and we'll show that in a second. So the second one is the classic limb ataxia, where you have the patient touch their finger to their nose and then to your nose and their finger to their nose and in your nose. The key to remember is that basically you want to see, do they have smooth movement between the two, or is this someone who's ultimately their finger is all over the place and they can't actually grab a hold of something because they're so shaky. The leg is the same thing. They run their heel up their shin, their heel up their shin to see if it's a smooth movement rather than a shaky movement. And the key here to remember is that if you've got someone who cannot move the limb at all, you don't give them the worst point, but you actually give them no points to see if they have ataxia. So it's limb ataxia. This is one of those ones that's kind of weird because it's like if they can't do it, it seems like they should be getting points. But in reality, what you're giving the points to is the ataxia as opposed to the ability to move or not. Sensory basically is do they feel or do they not feel? They should have normal sensory to even touch. Pinprick is often something you see done, but in reality most people just say, can you feel me touch? Can you not feel me touch? Where is the touch at? Is it the same? Is it different? If you have a neurologist doing a full score, they may actually bring in a pin or a broken Q-tip or something like that. Typically, I just simply have them, I touch their face. Does this feel the same on this side as the other side? Does it feel the same on this arm as the other arm? Does it feel the same on the leg or not the leg? And pretty often you can get a pretty good sense of what's going on. Best language. Remember we talked about people not being able to describe what's going on? This is the official picture that the NIH stroke scale puts out, and ultimately what's supposed to happen is the patient's supposed to be able to see the entire picture, right and left. They're supposed to be able to identify the fact that the kid's fallen off of the chair, they're stealing cookies from the cookie jar, the lady's doing the dishes, but the water's running all over the sink. And you will have some people that are unable to see the whole picture. They may be unable to identify what the objects are. They may not be able to speak and tell you what's going on, but ultimately they're looking with this best language of comprehension of what's going on in general. I often see the docs skip this one, but what they are doing is making their assessment from how the patient is responding to whatever else is going on. And I will tell you, even though it's taking us a while to walk our way through this NIH stroke scale, you will, once you see docs get good with it or you get good with it, you'll find that you can do it in as few as maybe like 3 minutes. It does not take long to do a full NIH scale once you remember all of the different steps to it. Dysarthria is where you give the patient a list of items that they're supposed to tell you what they are, and it's like a glove and a cactus and a hammock and things like that. And basically here you're looking for the patient's crispness of speech. If they start to slur their words or they're not making nice, crisp sounds, this is where you talk about the patient having dysphagia. This is another list that very frequently you see the neurologist skip simply because in the long run what they've done is they've held up an object and they say, tell me what this is. Or they're listening to the patient as they're speaking to them. How does the patient speak back, and is that language crisp or not? And they can get a pretty good idea. There's been times when we've had the patient come in and we talk about word salad, and it's like they're making no sense whatsoever and their speech is slurred. These are the things we're looking at when we're talking at best language in dysarthria in our patient. Extinction and inattention, remember, was one of those ones where the patient we've talked about basically doesn't recognize that you're there. They should know that they have both sides of their body, that they can respond to you from both sides of their body. They may recognize that one side is not working as well as it's supposed to, but if they don't even recognize that they have one of those sides, they have what's called extinction and inattention. And they can have no abnormality, which is more typically what I've seen with some of our stroke patients. But I have actually had patients come in that if I was on their right side, it was like I was not there whatsoever. And if I walked around to the left side, it was like, well, hi, when did you come in the room? And you were there in the room the entire time. They may not, you could hold their hand up in front of them, they may not even recognize that it's their hand if they have profound extinction when you're assessing these folks. As I mentioned, some places nurses are doing what's called an abbreviated stroke scale. This is especially if they're doing them every 15 minutes during the lytic administration. Typically what we do is we look at what's the patient's alertness, how is their smile, how are their arm and leg working, what's their vision like, and what's their speech like. It gets the main parameters, but ultimately it cannot be the final assessment. There needs to be a full NIH stroke scale done on this patient, but it does help if you're doing those Q15-minute ones. So it's a thought that's out there. A quick review: NIH stroke scale, level of consciousness, question A, B, and C. What's their gaze like? What's their visual fields like? What's facial palsy do they have, or deficits? Do they have deficits in their motor on the arm, motor in their leg? How well can they move their limbs? Again, sensory, motor, leg, and face. Language, how well can they speak? How well can they describe things? And do they have extinction? With the abbreviated stroke scale, assessments are starlighted there for you to see as you're doing your assessments. The key here, I think, also to recognize is what's the significance of this number? Why are we busy doing this? This number is the official NIH stroke scale. It's not the abbreviated stroke scale. And always be careful to remember that one does not get mixed up with the other in the charting system if someone's looking for a stroke number. But basically we know if they have an NIH stroke scale of a 1 to a 4, it's a minor stroke. And remember, some of our worst strokes or basilar strokes actually, in fact, can have a 0 for a number as far as NIH goes, and they're still having a significant stroke because it's all related to that basilar artery and maybe dizziness that's incapacitating. A 5 to 15 is a moderate stroke. That patient still may have a good outcome. A 15 to 20 is going to be more of a severe stroke, and the 21 to 42 is the very severe stroke. And you'll find that docs will kind of look at these numbers to help make the decision whether or not they should give fibrinolytics, if they should go to the interventional lab, and or is the patient basically, you hate to say are they salvageable, but is this something that you need to make a decision? Could it make a difference between life and death? One of the things that comes into play at this particular point is you start talking with family about quality of life with these people. 21s to 42s, especially if you start to getting those high 30s to 40s, are pretty significant. And it's going to be a long rehab, and is the patient going to be able to survive it? Those are some things to consider. So to recap, signs and symptoms of strokes, we've talked about a lot of different things over the last hour or so. But remember, a sudden onset of weakness or numbness of the face, the arm, or the leg, especially if it's on one side of the body, and you need to get that when was the last known normal time in there, because it's not when did they notice it, but when was the last time they were known to be normal, because that's going to start that clock ticking. Remember also, could it be sudden confusion or trouble speaking, trouble understanding? Is it sudden onset of trouble seeing? You notice the key word is sudden. Those, sudden trouble walking, sudden dizziness, sudden coordination problems, or that sudden severe headache. Because remember, signs and symptoms of a stroke may be a bleed stroke, and bleeding into the brain is something that we don't give fibrinolytics to, but we may need to think about treating that patient as well. To catch those subtle strokes, be suspicious. Remember, not everyone has the classic one-sided facial droop, weakness, or slurred speech, but they have those sudden things that we've talked about. We just mentioned several of them, but to me these are important enough that we need to watch for these, and often these are the strokes that are missed, simply because what we find is they go, oh, well, it's not the classic stroke. And what we're noticing is as triage nurses become more suspicious of sudden symptoms, asked to have a stroke code called, we're catching strokes a lot more frequently, and we're treating strokes a lot more frequently, simply because we're more aware. And I think that's one of the things that's good about our stroke system in Minnesota, is that we're recommending that people get the knowledge to seek care early, be caught early, and be treated early, and we can have better outcomes for our patients. Remember, time is of the essence. We need to know that last known well time. You've heard me say this multiple times, But ultimately, that is the key. When was the last time they were known to be well, not when was the last time somebody thought they noticed the symptoms. The clock starts at known well time. The time for treating has elongated just a little bit recently. If you hear the classic, you need to start treating within 3 hours. Recently, that has been increased to 4.5 hours from symptom onset if we're giving IV fibrinolytics. If the patient's going to the interventional lab, they may have a little bit longer time. Each neurologist has a little bit different idea as to how long that longer is. The key is that if we've got sudden onset of symptoms, bring them in, give it a call, identify what's going on, and make sure that that patient is being thought of as a possible candidate for stroke therapy. The other thing that we need to remember is that we have to make sure that this is a clot stroke rather than a bleed stroke. So we need to get a CAT scan or computerized tomography scan of the head, make sure that there's no bleeding into the head. Obviously, we don't want to give something that dissolves clot to somebody who is bleeding in their head, so that CT scan is going to be paramount. If we have a patient who has blood pressure that's really elevated, one of the things we're going to need to think about is controlling that blood pressure just as we start to get those fibrinolytics into place. And we need to remember to rule out some of the mimics, and we're going to talk about those for a few minutes. Again, don't think, oh, it's a mimic when a patient comes in with a symptom, but as you're thinking, oh, it could be a stroke, but I need to make sure that I don't have a mimic that I'm busy chasing down a rabbit hole after. So you need to do both of them, and you need to do both of them rapidly. One of the stroke screening tools that's out there is the Los Angeles Pre-Hospital Stroke Scale. It's kind of one of those ones that captures some of those mimics. That's the reason I included it in the talk here. A history of recent seizures. One of the things we'll talk about in a few minutes is Todd's paralysis, but that may be one of the stroke mimics. This stroke screen also talks about when did it start, last known well time. They ask the question, pre-symptom quality of life, because that's going to make a difference. I'll mention here the idea of DNR does not mean you do not treat strokes, but it's one of those things to look at what has that patient considered for treatment in the future as they were identifying what did they want done. I'm not convinced that people who write their DNR and their end-of-life decisions are thinking about strokes all of the time. They're probably thinking about their heart having stopped. But this is one of those things that people should consider when they're writing up their advanced directives is, if I have a stroke, what would you like us to do? Because if you have a 90-year-old who's still doing laundry and raking the grass and shoveling the snow, this is probably you might want to consider giving fibrinolytics to, because their pre-symptom quality of life was great. But if you've got a patient who has had a stroke but prior to that stroke was totally incapacitated, that may be somebody that they would say, do we really want to do this? Blood sugar will be something we'll talk about, but the blood sugar needs to be within normal limits when they're doing the Los Angeles Pre-Hospital Stroke Scale, as well as now they're looking for signs and symptoms related to stroke. These, again, are the classic ones. They're not looking for things like how is their vision and things like that, but they're getting the basic ones there. So to kind of launch into our mimics, that's the reason I put this in. Stroke mimics, probably the most commonly seen stroke mimic is a hypoglycemic event. I will say, though, that many times I have seen patients recreate their stroke symptoms if you don't keep that blood sugar where it needs to be. Remember, the brain needs sugar. So if you have someone who comes in with one side deficit, one of the first things we do as part of the process is to actually get a blood sugar and treat blood sugars appropriately. I have not seen as many hyperglycemic related strokes, but hyperglycemia is not good for your neurologic patient. But more typically, if someone comes in with stroke symptoms and they're sweaty and they're combative, don't be afraid to start thinking, could this be one of my hypoglycemic patients that needs to have their blood sugar fixed a little bit, and have fixed a lot of strokes with an AMPA D50, but then need to remember that this patient needs to be continued to work up for that stroke because they've probably got an area of the brain that's functioning marginally as it is, and that's the reason the hypoglycemia caused one-sided deficit as opposed to both-sided deficits. I recently had a stroke patient that the blood sugar was in the 50s. We gave an AMP of D52. He woke up. His symptoms went away. The neurologist happened to have come down because we called a stroke code. And as she was doing the assessment, we watched him develop a stroke again because his D50 had worn off, and we needed to give him more D50. Now, do you want to feed him right away? Boy, I don't know, until I've gotten a swallow study done on him, and I know that he's going to swallow anything I give him real well. I don't know that I do that. We ended up hanging a D5W on this fella, but it's one of those things to consider, that low blood sugar can actually be or appear to be a stroke. Other stroke mimics, we have seen people who have had migraines that have stroke symptoms. You need to rule them out. And sometimes, even though they have a history of migraines, they can still have a stroke. It's probably related to vasospasm of one of the cerebral arteries. We talked a little bit about seizures would be one of the other reasons you may run into someone who is having stroke symptoms. We'll talk about that a little bit more in a few minutes. We've talked about blood sugar disturbances. In fact, any electrolyte abnormality can mimic a stroke. Sometimes just low blood pressure can mimic a stroke because part of the brain is just basically tenuous enough that ultimately this person is going to have stroke symptoms, and it's because their blood pressure is too low. Also, if they're hypoxic, the brain not getting enough oxygen along with low blood pressure may be enough to cause stroke symptoms, that as soon as the patient gets enough oxygen and a decent blood pressure, all of a sudden their stroke symptoms go away. For some reason, occasionally they'll have a transient global aphasia and just can't remember what's going on. I know sometimes we jokingly sit there and go, I can't remember things, call stroke code. But in reality, sometimes it's just simply they have some global aphasia for a few minutes. It may be a peripheral nerve disorder where they've fallen asleep on their arm for a short time or a long time, or they have carpal tunnel, or they have impingement on a neck nerve or something like that. Those are some things to consider are stroke mimics. But basically, you need to be thinking stroke first, rule that out, and then go ahead and investigate the mimics. In the process of ruling out a stroke, we get that CT scan, and we may find the intracranial hemorrhage. We may find a tumor that's growing, an abscess that's growing. I've seen that. And I have had stroke patients that truly were psychogenic, and they were pretty convincing. And it was all related to there was something going on in their life, but you had to rule out the stroke first. I'm just going to lastly mention TODS paralysis one more time. One of the reasons that many of the different stroke assessment scores look at did they have a seizure is that for some reason, status post-seizure, occasionally one side of the brain will wake up before the other side of the brain will wake up. Why that is, who knows? The youngest person I remember with TODS paralysis was a 5-year-old that scared me to death simply because I knew the child had had a febrile seizure. The story was perfect for a febrile seizure. I was typically comfortable with a febrile seizure, but when this child was only moving one side of his body after his febrile seizure and was waking up, it was like, holy cow, what's going on here? And since that time, we've learned more about strokes, and we're seeing that occasionally this is what happens. So once again, think stroke, do the stroke protocol, but if the patient ends up not being a stroke, but it's related to the seizure, say, well, at least we ruled it out. We made sure that the patient was safe. The other thing to keep in mind is sometimes the patient will seize because of bleeding in the brain, and then you're thinking stroke as well, but we're thinking bleed stroke. Migraine we've mentioned earlier. I still remember someone I worked with who suddenly could not speak and suddenly couldn't move her arm, and when they did the entire workup, it truly was a migraine for this person. Probably the last stroke mimic we'll talk about right now is the Bell's palsy. Is it Bell's palsy, or is it a middle cerebral artery occlusion and a stroke? And one of the things to kind of keep in mind is basically, yeah, theoretically, what you can do is you can prove that if it's both the upper and the lower part of the face, it's probably, and notice I highlighted the word probably, going to be Bell's palsy, but it's safer to assume it's a stroke than otherwise, at least for you as a nurse. If the neurologist or the ER physician wants to call it Bell's palsy, that's their prerogative, but you as a nurse is probably smarter and for patients better safety, consider that it's a stroke and bring that patient right back to be seen. Oh, I lied. One more. Over the years, and we've mentioned these already, but I've had nurses say, oh, I had a patient who came in with a stroke, and this is what fixed it. It was hypotension, it was fever, and hypoxia were common causes that as soon as they corrected those issues, that patient did better. So let's say, what should you do? We've talked about patients that are having strokes. We talked about recognizing symptoms. We talked about mimics. So you've got somebody that shows up with stroke-like symptoms. What are you going to do? Remember, they could come in by the ambulance crew. They may come in by a private vehicle. Or, and this is one of the things we often forget, just because we're in the hospital doesn't mean we can't suddenly have a stroke or our patients suddenly can't have a stroke. So what are we going to do? What is the process for taking care of a patient with a stroke? That's what we're going to cover next. So the typical stroke code process, and it doesn't matter where you go, there's a little bit of nuances for everybody. But as soon as someone recognizes the symptoms that someone's having a stroke, they should call a stroke code. They need to establish that last normal time. When did somebody actually see them and they were normal? We want to think about getting 2 IVs, one just for everything else and one specifically for the fibrinolytic that we're going to give. But the key here is if you're having trouble, don't delay your CT scan, because in the long run, that CT scan is going to be highly important. If in the process you can get some blood off of your IVs, go ahead and grab some blood. One of the tests that is going to be very important is that INR, if you've got somebody who's on warfarin or Coumadin or a medication similar to that. If you're going to be giving any dyes, a creatinine is going to be important. So if you can grab some blood, go ahead and do that. But the key there is getting your patient over for that CT scan. If you need to work with CT to come up with a way to have that table emptied off so that they're there, or you need a way to get that CT scanner turned on. Those would be some of the things to think about. Somewhere along the line, if you can get a rhythm strip and a 12-lead, don't delay the CT scan. But remember, atrial fib is a high risk for someone having a stroke. You want to know what that rhythm is. You want to remember to check that blood sugar, because remember that blood sugar may be the reason that that patient is having some symptoms. You'd like to be able to know what the patient's weight is so someone can start doing the calculations to mix your TPA, which is your drug of choice for your person having a clot stroke that's sudden in onset and the symptoms are still less than 4.5 hours. You want somebody to get that NIH stroke scale done, or at least the abbreviated one initially, but somewhere along the line prior to giving your TPA, you want an official NIH stroke scale. You want to be doing vitals and neuros, etc. You want to ask about blood thinners. And if you get a story that the patient's had a recent stroke or is on Coumadin, that may in itself be a contraindication to TPA, but you still keep moving along, because we've had patients who they could remember they didn't take their warfarin, and you know what? They ended up being a candidate for TPA. So it's one of those things. Keep moving along until the last minute when they say yes or no as far as giving the medication. If your patient has a stroke in-house or in the hospital, again, a stroke code should be called. But one of the things that you may not need to do if you're an in-house nurse taking care of a patient and viewing this program is you may have your lab results already. Maybe it's a matter of checking the chart rather than drawing more blood. You're going to want to know what the blood sugar is for sure, but ultimately it's one of those things that perhaps you can pull a chart up and see what's the rhythm been, what's their INR been, what's their creatinine been. It may save you a few more steps and a few tests that you don't need to do if you're thinking ahead and realizing I have this data already. Most stroke code processes are set up for the ED, where the patient comes in, has not been assessed previously, and so they're starting from scratch. Whereas if the patient's in the house and had a stroke and they have lab tests sitting on file, you may as well take advantage of those. Your stroke code team can consist of a variety of different places. It depends upon your facility, and you have available. One RN is imperative. A second RN is nice. We have been known in our facility to run it with an RN and the pharmacist, because the pharmacist is going to be mixing the med. Sometimes that other RN is the one that's going to be taking care of the med. You'd like a physician involved. It'd be nice if you've got a neurologist and an ERMD. Sometimes it's just going to be the ERMD managing it and talking with the neurologist as the neurologist is receiving the information. Part of your stroke team would be your CT tech and maybe your lab tech, unless you're going to be drawing all of your blood. But look at your facility and look at who responds, and think outside of the box. Don't always think that it has to be a doctor and a nurse on your stroke team. It could well be other people that are part of the process that would make an excellent stroke team. And I will tell you, one of the best advocates in my facility is our CT techs. They help us out the most with our stroke codes. That rapid trip to CT for an unenhanced scan is looking for a hemorrhage. Basically, what we're looking for is bleeding in the brain. And if the patient has bleeding in the brain, basically, I'm not going to say we're done, but we're not going to give TPA to the patient. And we start looking at the stability of the patient and determining if something needs to be done more or less for that patient. Some places will do a unenhanced scan while they're waiting for the creatinine to determine if it's safe to give angio dye to this person. And if it's safe, the creatinine's good, the kidney function is good, they may actually do angiograms and right away without even taking the patient off of the table. Other places will do the CT scan, bring the patient back to the ED, start the treatment, and then do angios depending upon their process. Third option may actually be to do an MRI, looking at perfusion and for ischemia. So your radiology department is a huge part of the treatment of a stroke. I will tell you that many places track door to CT time. Nationally, there is a goal of trying to get your CT medication in, getting your stroke medication in within an hour of arrival. Your CT should be done with a goal of less than 20 minutes. Most places are getting that done without a lot of trouble, especially if they can get a heads up to the CT people and get that patient over there as soon as possible. The odd thing about CTs is it's going to tell us if we're dealing with a clot or a bleed stroke. Hemorrhage, which is what this particular scan is actually showing, is easy to see. Oddly enough, the CT scan will more often be normal in an early stroke. So it's like when they say the CT scan is normal, you go, oh, then why are we doing something? But in reality, the CT scan, as ischemia starts to develop, the CT will start to change, and you may actually see clot sign in your patient, and then this tells us we have a stroke that's a little bit older. And sometimes we need to then start thinking about, could there be other scans that we might need to do? So, again, basically knowing the type of stroke is huge. A bleeding stroke is treated differently than a clot stroke. They may actually have to go in and aspirate the blood, depending upon if it's something that's aspiratable. More often than not, basically the body has to absorb the blood. Sometimes we have to take care of blood pressure with this person, but ultimately in the long run, this patient, if they're bleeding, we're going to be treated differently than a clot stroke. If it's a clot stroke, it's going to depend upon how long the symptoms have been going on. Again, remember, if it's less than 4.5 hours, you may be giving IV TPA. If it's longer than 4.5 hours, or if it's a huge vessel that's being affected, you may find that that person's going to interventional radiology. If it's a shorter time, but the TPA doesn't seem to be working, again, the patient might be going to interventional radiology. But the key there is we can all get started giving TPA very quickly. Sometimes you'll find that the CT people or the MRI people or the neurologist or the neuroradiologist will ask to give dye into the patient. It gives a better picture of what's happening. And here are two pictures of a CT angiogram and an MRI angiogram. Basically here, both of them show the vessels much more clearly. They can show you where the occlusion is. The neurologist is able to identify if this is a bigger clot versus a smaller clot. The key here is the dye. Knowing the creatinine and allergies prior to giving the dye are going to be important. And then if we have somebody that may be having dye-related problems, we want to be able to flush those kidneys as quickly as possible. So just kind of an awareness related to that. If you're lucky enough to have the other perfusion studies that can be done at your facility, basically what can happen is the neurologist can order special testing that will identify even how old the stroke is. There's some places that are treating wake-up strokes with the idea that the stroke may have only occurred an hour prior to the patient waking up, but because the last known or less normal time for this patient was the night before when they went to bed, theoretically they are outside of the window of treatment. Well, if we can do perfusion studies, it's possible that we find that the patient, in fact, is eligible for the fibrinolytics. So you may hear the doctor ask for an MRI or a density-weighted imaging or perfusion-weighted imaging. And just these are some pictures of those various things. And that's why you're hearing more and more docs ordering different tests. These are the tests that may help exclude the stroke imitators, especially like the migraine or the TOTS paralysis. So if the doc isn't real sure, they may order these types of imaging to help them determine if they need to treat the symptoms or not. So again, basically time is the challenge. Giving fibrinolytics outside of the treatment window has led to bleeding. I don't have a specific number related to that, but that's always the fear they put us in. And those of us who have been treating strokes long enough have seen patients who were getting better, went up to ICU, and then later on bled and ended up with the worst stroke symptoms. So we're always so very careful to make sure that we get this patient treated in the right time frame. Some of the typical strategies for treating stroke, we now say the maximum time is 4.5 hours for intravenous TPA from the symptom onset. They can do intraarterial thrombolysis, or basically squirt some of the TPA right onto the clot itself. Docs vary with this time frame, but typically within 6 to 8 hours of symptoms onset, they may do that. They can actually now go in and pull the clot out after the 8 hours. Again, there is risk with this as there is risk with the intraarterial thrombolysis, but each neurologist has their own theory on these, and this is why many times these patients initially start with IV TPA and then they are transferred to facilities that have interventional radiology capability, because in the long run there are more options for this patient. We've seen some excellent outcomes with patients who've gone to IR for treatment. TPA, just a little bit about that. Basically, it was approved in 1996. Alteplase was the name for acute ischemic stroke that basically they were approved. It had to be given within the first 3 hours. Basically, in 2009, that window was expanded to 4.5 hours. There were additional exclusion criteria, but ultimately each physician, neurologist physician specifically, will make their decision as to how long of a time frame they're comfortable with. But ultimately the gold standard is that if we can give the time window appropriately, we want to give that TPA as soon as possible, because remember, those brain cells are dying, and if we can do it within 60 minutes of arrival to the ED, that would be great. I can tell you our process at our facility, we were getting it down to about 20 to 25 minutes from door to TPA time. So as you practice it and get more comfortable with it and work your system, you learn how to do it quickly and easily. And if there's a system in place, you'll find that it's not even as scary as it needs to be, and you can meet that 60 minutes for sure, and you can get it in even faster as you become more comfortable with the process. One of the other things I recommend is early on figuring out who's going to mix the med and how much are they going to mix. Basically, this is a dose-related based on patient weight. We'll talk about this in a few minutes more. But the earlier somebody can start doing the math, the better off you are. Know that the company will typically reimburse you for med that is mixed up and not used as long as you know that it is not a bleed stroke prior to mixing it. If you just automatically mix up TPA for every single stroke code you call, they'll start to get a little unhappy. But if you have your CT scan done and it definitely looks like you're going to give it and the drug is mixed and then you don't give it, the company is very good about reimbursing you because TPA is not a cheap drug. But when you compare the cost of taking care of someone with stroke symptoms for the rest of their life compared to the cost of the TPA, and that is currently the only FDA drug for stroke, it's a cheap medication to give to people. The dosing on TPA is basically 0.9 milligrams per kilogram. There is a max dose of 90 milligrams. What happens is once the dose is mixed up, 10% of that total amount is pulled into a bolus, which is given over about a 2-minute time, and the rest of the dose runs in over the next hour as a drip. That's the reason you often hear the word drip and ship, because what people will do is give the bolus of the TPA, start the drip, put it on their pump to run for the next hour, and then ship them to a facility that is a primary stroke center. You can keep them and watch them there at your facility, which many places are doing now as they have neurologists work with them. Other places will continue to ship them. The key there is to make sure that whoever you're shipping your patient with, they can monitor that patient for signs and symptoms of improvement or worsening. The biggest thing we ran into with TPA was that people forgot to make sure that the last of the TPA, which is in the IV tubing, was also given. So once the TPA is given from the bag that you've mixed it into, you then need to make sure that the line is flushed into the patient, or ultimately they don't get the dose. And the flushing should be at the same rate of drug administration that you were doing prior to getting to what looks like an empty bag. So you would keep the rate at the same rate that you were before. Some inclusion criteria, we could certainly read these to you. I'm not going to read them out loud, but basically the key here is anybody who has a clearly defined time of onset and it's less than 4.5 hours, they should be getting IV TPA if they have stroke symptoms that are consistent with ischemic stroke and they're continuing.